Great. Good afternoon, everyone. So before the Woodfire, it's my tremendous pleasure to introduce you to this year's recipient of the Christopher G. Wood Rising Star Award. So for those of you who didn't have the chance to meet Dr. Wood, he was a true surgeon scientist, and he was the chair of the board of directors of this organization, the Kidney Cancer Association. Chris was passionate about advancing kidney cancer surgery and mentoring future urological oncologists, and it's in that spirit that this award was created. This year's recipient is Tom Mitchell, consultant urologist at Addenbrooke's Hospital and researcher in the Early Cancer Institute at the University of Cambridge. His career has been dedicated to improving our understanding and treatment of kidney cancer. Tom's career path has been unique. He first earned a degree and PhD in engineering at the University of Oxford before returning there to study medicine. He trained in the east of England in urology and built a research path that was shaped by collaboration and mentorship. Two key mentors were Professor David Neal of Protect fame in prostate cancer and Professor Peter Campbell at the Sanger Institute. David recognized Tom's potential to bring engineering precision to cancer research, and Peter helped him to develop into a bioinformatician, skills that Tom now uses to bring clarity to complex biological data. When I arrived in Cambridge 10 years ago, I made it a priority to recruit Tom to research kidney cancer at a time when prostate cancer was really calling to him as well. In 2024, Tom was appointed as the Krishna Nang Distinguished Group Leader in Urological Cancers in Cambridge, supporting his mission to turn deep biological insights into better patient outcomes. Tom's research focuses on two areas: predicting how cancers behave and also understanding the tumor microenvironments with response to therapy. And his team use advanced sequencing on annotated patient samples to uncover new drivers of disease and refine classification of kidney cancer. This has resulted in promising new ways of treating kidney cancer, and of course those studies have been published in the top tier of journals. Beyond the lab, Tom is an expert surgeon and a generous teacher. His trainees often highlight his thoughtful mentorship and willingness to share both technical skills and research insights. The Christopher G. Wood Rising Star Award honors early career investigators already making a real impact in kidney cancer. Tom is a clear example of this, combining surgical excellence, research leadership, and true dedication to clinical and academic communities. So Tom, congratulations, and we're looking forward to hearing your lecture. Thank you.
Thank you very much, Grant, for those generous words. I remember clearly coming to my first IKCS meeting, which was in Miami in 2017, and I listened to Chris Wood talk about his career advice. And one thing I particularly recall is him saying that he had this strong pull of the operating theatre, like he was being seducted to return there time and time again. I don't quite share the same sentiment, but the principle of finding the correct balance between your clinical work and your academic work is really quite a challenge. And in particular, when I started my journey, which as Grant says is quite unusual, I started with a PhD, with a master's and then a PhD in engineering science, where I developed a needle-free vaccination system, and that really kindled my interest in the human body and how technologies may modulate disease processes to improve life. And that led consequently to my medical degree, and then 4 years of basic surgical and medical training in a small district general hospital. And at that time, I was pretty sure that I wanted to do surgery, and I had an idea that it would be remiss if I couldn't find some sort of way to blend these two expertises together. But I didn't really have an idea how to do that. until I had a conversation with Professor David Neal, who many of you here will know, who was the professor of urology in Cambridge and had an interest in prostate cancer. And he had these academic clinical fellowships which he was supervising, which allowed us to ring-fence essentially 25% of my time to research. But at that time I had really no idea what to do. And I came across this idea. Having heard that the androgen receptor is important in prostate cancer, I thought I would link the expertise of Shankar Balasubramanian with Professor David Neal's expertise to see if we could target that. And as a consequence, I managed to get some seed funding for my salary, and within 8 months' time, we managed to publish. I realized, though, that it didn't really use my previous research strengths, and I was really looking for something to better marry engineering, say, with medicine. But the pilot study gave me success in this welcome interdisciplinary fellowship, which gave me 1 year. And I felt at that stage the Department of Biotechnology might be able to find that synergy. And I looked into whether we could use nanobubbles as therapeutics in urological malignancies. But it became clear that that was far too high risk for an early career person. There's no early or medium-term gains. And in fact, what I really wanted to do was to work with Peter Campbell. Unfortunately, he's an extremely busy person. And each time I tried to contact him or email him, I had no response. And it was only afterwards at his leaving party where each faculty member stood up and said, "You have to reply to your emails, Peter," that as I realized it wasn't just about me. But I managed to get contact with one of his postdocs, David Wedge, who's a bioinformatician, and he had some really interesting ways to look at copy number changes in cancers. And I worked with him to take it one step forward to infer how cancers develop over time. And that gave me enough pilot data to be successful in a National Institute of Health research academic clinical lectureship. And that was in kind of 6-month blocks, 50-50 time, so I could spend 6 months learning a subspecialty of urology and then 6 months looking at an academic question, which was based at the Wellcome Sanger Institute, with my clinical work based at Addenbrooke's Hospital there. And the methods we worked on before first applied in prostate cancer, but afterwards then became the basis of setting up the evolution and heterogeneity working party of the pan-cancer analysis of whole genomes. And it was a really exciting time at that stage, because essentially I had complete academic freedom. I could flip from one thing to the next. And at that time, we didn't have a kidney research program in Cambridge that was comprehensive or well thought out, but we did have a biobanking strategy, and Grant joined the team. And through all of those things, I was able to lead with Sarah Teichmann and Sam Bijati, shown here, the first human cell atlasing of kidney cancers and benign kidneys. I could also look at mechanisms of tumor initiation, but I was also afforded freedom to learn about development through somatic mutations, pediatric tumors, and also look at things like the field effect in bladder cancer. And of course, the major thing I'll remember from this time is the Cell paper, which you may all know. I was fortunate to be offered the opportunity to work on and analyze the whole genome sequencing data from the TRACER-X study. And this was supervised by Peter again, but working closely with Samra. And we came to this remarkable conclusion that all of us in this room in our adolescence years would have a few hundred cells in our kidneys that have undergone the first mutational change on the pathway to generating kidney cancers. And it's only the unlucky amongst us who have a subsequent VHL mutation in a short period of time, or those patients who are born with a VHL mutation who go on to have a clinically visible tumor perhaps 20 to 40 years later. And this really frames the opportunity for early intervention, early detection, and prevention of these tumors, and has motivated lots of my work since. The success of this work enabled me to get a Clinician Scientist Award, which is essentially a seed fund for 5 years, which will pay for your salary, but also some staff and some and consumables. And this coincided with my consultant post in Cambridge. And although the locations of my work hadn't changed, and on the face of it, my work hadn't, the demands changed quite a lot, because as a consultant urologist, you're then completely accountable for your patients in your work, and on the research side, you're completely accountable to what you promise your funders and your team. And I was hugely fortunate to have a really supportive team from the clinical side, as showed there, mentored by Grant Stewart, but also have an exceptional team on the scientific side at the Sanger Institute, mentored by Peter Campbell. And through this, I don't know how to judge success, but we had a smattering of papers. I had a busy time clinically, but I think one of the major things I'm most proud of is how my trainees and the people that I've mentored have gone on to do greater things. For instance, Royan Lee, who did a large part of the analysis in the cancer cell paper. He's now faculty at MD Anderson Cancer Center. And it's really lovely to see these people go on and have independent group leader positions of their own. I'm really excited about future research. I talked a little bit about this yesterday. I was really fortunate to get a philanthropic donation to allow me to continue this work for the next 5 years. And I understand that the headwinds in many of our academic institutions are such that we do need to now look for alternative ways of funding our research. I'm really excited about the project at the bottom, where we're trying to precisely decipher the difference between the seed and the soil in kidney cancer, so to be able to tell the difference between intrinsic cellular properties and those that are modulated by the tumor microenvironment. I'd like to finish by just saying that we talk a lot about our successes in clinical work and research, but we talk far less about our challenges and failures. I won't talk about those today, but it's because of the help and the support and the motivation from lots of the people that I show here that this work's been made possible. So I'd like to thank all those people for this award, and I'd like to thank you very much all for listening.
So, good afternoon, everyone. My name is Arnaud Méjean. I am a urologist in Paris. Yes, and I have the pleasure to present the Woodfire with Tom Pauls. The panel is composed today with Lisa Pickering, who's medical oncologist, Tom Waddell is medical oncologist as well, Michael Steiler and Tom Mitchell. They are urologists. Obviously, Tom is a medical oncologist. So there is actually 3 Paul: Paul P, Paul M, and Paul W. So we try to find the good during the question. So I just would like, for those who are not very familiar to the Woodfires, what are the Woodfires? Woodfires are created by Chris Wood, who was a urologist in Houston, MD Anderson, and I would like here to put what are the roles he created. Data not given here is considered to be within the limits of normal. If you want to introduce the patient to a trial, name the trial, and it's objective. If you want to treat a patient with systemic therapy, name only one regimen that would prescribe. Never put decision on the patients, but come up with a clear recommendation, assuming the patients will choose the one option you offer. And the best one is, don't tell me what you could do, but what you would do. And the principle of Woodfire is to challenge the panelists. So we started with this man, it's case number 1, man 63. He has an hematuria, and the CT scan shows a right renal tumors with lymph nodes, with a vena cava thrombus, no thoracic lesions. He has an hypertension. He is smoking. He is a smoker. 31, the BMI was 31, and eGFR was 63. So this is the CT scan. And my first question to Michael Steyer is, what you are doing?
Oh, I see an opportunity for free champagne here for the rest of my life and would take him to surgery.
Surgery first, okay. Tom M?
So, I agree, but I would wonder about sometimes the benefit of a biopsy here. If he's got lymph node positive disease, that you're not going to clear all of his metastatic disease. However, he's young. He's young for one of our patients. He's fit for one of our patients. You can clear the majority of the disease. You can clear the other lymph nodes. So I would agree with Michael. Surgery.
So you discussed a treatment before the surgery? I don't understand.
Arnaud, I confess I missed. I was too distracted by the fact he was a champagne grower. Were there
Yes, that's right.
Was there metastatic disease?
Okay.
Was there metastatic disease? I missed it.
Just lymph nodes.
Just lymph node.
So Lisa.
So I think that, so if this was presented in our MDT, our tumour board, then I would be asking my surgeons how technically resectable that is. I'm a medical oncologist. I cannot answer that question. Do you have the right imaging? And if there is a question about the technical resectability, I would go to Tom Mitchell's point of, do we need a biopsy here? Because to my eyes, this looks like quite a nasty tumour.
Okay. So the biopsy is a clear cell renal cell carcinoma. And we decided a treatment with Pembrolizumab with a good tolerance. And after 3 cycles, between December 22 and March 23, he has macronodules, lymph nodes, progression of size of retroperitoneal lymph nodes. And we decided to make another CT scan to be sure of the progression. And between 6 weeks, there is clearly a progression. So what do you do? Lisa?
So we know that renal cell carcinoma is a heterogeneous disease, and one thing that occurs to me immediately is I don't actually know if I trust that biopsy that says this is a grade 2 renal cancer. I don't think this is a grade 2 renal cancer. That in itself probably does not affect my decision making, but I'm nevertheless questioning, and we've talked about this during this meeting, that I personally doubt that that is a grade 2 cancer. Nevertheless, here we are with a definite clear cell cancer and a man with progression and an early repeat scan after 6 weeks showing continued progression. So he is resistant to this therapy, in my view. He has confirmed progression with new sites of disease and resist progression. So I would be switching him to second-line therapy. I would choose cabozantinib in this setting. If he had tolerated this well, I see no reason not to start at the standard full dose of 60 milligrams once daily.
Michael?
So this is, it doesn't surprise me a lot that this happens to the patient, but now we have a situation where we have 2 lost chances here. One is me getting my lifelong champagne supply. The other is that now we have a patient who is progressing into metastatic disease, and he has about 2.5 pounds of active tumor in his retroperitoneum blocking his vena cava. And there's no rationale to put him through surgery in this situation where he is actively progressing. That's why I voted for initial surgery and then either adjuvant therapy or continuous systemic therapy. In this situation, what I would do, I'm still concerned about this primary tumor and what it means to the patient in the future. So I would probably offer him high-dose hyperfractionated radiation therapy to that kidney tumor in combination with immunotherapy. I don't think that he had a chance of real therapeutic failure to the therapy that he got introduced to, but that is too early to really have an impact in terms of efficacy, so I would continue him on that therapy. What we do in those cases is that we do one fraction, just at about 7.5 to 13 grays, and then wait for a month, do another one, wait for another month, and we can shrink those tumors quite nicely with those hyperfractionated approaches.
Okay, may I ask you to have very short response because we have so many cases. Tom W., you are happy with that?
So I think he's got small volume progression. Did you continue the acti-pembro between the May and the April scans?
It's up to you.
Okay, so I mean, I think you could carry on acti-pembro a bit longer. He hasn't had a lot of exposure.
But he has a progression.
But if he's truly progressing, then I agree with Lisa, you need to switch systemic treatment. I might go for lenvatinib everolimus combination second line in order to still have cabozantinib as a third line option, just the way that the funding is in the UK.
Okay.
And I would definitely restage him fully. Actually, that's another really important point. So I would perform some form of brain and bone imaging for a man who is progressing.
Okay, we change, and we start pembro-lenva with a good tolerance, excepted an episode of diverticulitis. But very interestingly, he has a very good response on the CT scan, as you can see. So, Tom M., what are you doing right now?
So have you seen a complete response in the chest and in the other lymph nodes? How much response have you seen?
So, sorry?
I was asking how much response have you seen in the chest and elsewhere?
This is the first CT scan, and at the beginning of the story, and the CT scan in January 24.
So I would advocate to take out the primary at this stage.
Okay. Michael?
So I wouldn't be in that situation in that case, but if I would be presented a patient like that here, I would not do immediate intervention here. I would wait for a little longer. I want to see patients to be in a stable situation for a longer time and not jump to surgical consolidation here. I want to see this is sustainable, they're doing well, and they're not progressing on the next scan because he seemed to be somebody who had a rapid progression under systemic therapy, and switching out lenva and axitinib, I don't think this makes a huge difference in terms of the
Although, Michael, is this not now 18 months later, looking at the dates on here?
Yes.
So he's had a good response to the len-pem, and I think this means it's a sustained response because it's 24.
Oh, I didn't see 24.
So yeah, no.
Yes.
So I think we've probably done a sort of
yes.
trial of
And you
time,
see the thrombus
continued response.
Okay, if
There is
he's,
downsizing of the thrombus.
if he's stable, otherwise this
There is
goes out.
a very, very good response on the primary tumor.
Yeah,
Nobody
I asked this
decided
question
to,
at my...
to make the nephrectomy?
I asked this question of my surgeons about 10 days ago for a man I thought I would never be asking that question of, who'd had a high-grade aggressive presentation, but has had an excellent and sustained response actually to cabo-nivo. And I asked this question of my surgeons just 10 days ago. Would you now take out this primary tumor that we thought we would not because of a similar magnitude and duration of response?
Yeah, I would.
So, Tom M., I would like to know what is the best direction of treatment before deciding the surgery for you, in this kind of situation? If you're putting the treatment during 3 months, 6 months, 1 year before to decide the surgery, considering if you have obviously a very good response on the primary tumor and the metastasis. In this situation, for example.
Yeah, that's That's a difficult question to put a number on, because it depends. It depends on a dynamic response, doesn't it? So if you find that the response has tailed off, if you see no evidence of metastatic disease, if you see your primaries static, so I'd say 3 to 6 months, I think, is reasonable.
And I think the reason for some hesitancy in answering is that the honest truth is we don't know the answer to that question, and we have to acknowledge that. So we're trying to estimate, we're trying to guess biology, duration of response. So I think the principle is it's quite difficult, but what people are looking for is a very good response in terms of quantity and some feeling that is durable. How durable is the exact duration you need? I don't know, but you need to feel it's durable.
Okay, we decided a right nephrectomy, a total right nephrectomy with a chivotomy and trabeculotomy, and the pathology was interesting. There is no tumor at all. It was a YPT0, and there is a complete regression of the tumor. So we see the patients in October 2024, and in February 25, he has no evidence of disease, and the EGFR is 62. Tom?
Thank you. Thanks for inviting me. I'll be quick. A 38-year-old female came in at Christmas time, I think it was last year, fit and well, recently returned for a long stay in Africa, a Caucasian female, non-smoker, weight loss, fatigue, went on a fitness retreat, long diagnostic workup under ID, couple of weeks, found out to have hematuria, then some flank pain, fever, lymphadenopathy. Did a PET scan, the ID people ended up doing a PET scan, showed lymph nodes and a renal mass, and indeed metastatic cancer, big renal mass. Actually, the MRI of her back showed a lot of bone disease there also. And she was struggling walking when we saw her. Performance status was dropping, and she was developing a transaminitis. So this is a young female. You've got these awful scans. Radiologically, it looks like a renal cancer. I guess the key question is, what do we do next? Who wants to start? Tom, this side, perhaps.
Yeah, so in this case, you need a histological diagnosis to know what you're dealing with.
Do you need that?
Yes.
So you've got a performance status of 3. She's got a transaminitis. Her mother came to me and said she needs treatment. We know that these new immune drugs are amazing. She's got a transaminitis. Things are getting worse. By the time 2 weeks' time, the mother says to me, are you guaranteed that she's going to be fit for therapy? Her performance status is currently 3.
I mean, you don't know what you're dealing with. You could be dealing with an upper tract urothelial cancer. You could be dealing with an RCC. I take it that they may all respond to immunotherapy, but the therapy...
Tom W., the mother comes back, says for a second opinion, and phones you up privately, and you agree to see them privately on the telephone. And she says, look, I need to start this woman, she needs to start treatment right now. We haven't got pathology. We think it's renal cancer. Her performance status is dropping. I want treatment without a biopsy. Would you treat her?
No, I would need histology.
And I would say we've got a one-stop biopsy clinic in Cambridge, so she'll go to that one-stop clinic, she'll get the diagnosis on the day.
But most centres don't have that facility, and I think it's amazing that you do, and it's brilliant to your amazing service that you offer. So we keep going. We didn't jump in. This is true, by the way, everything this is okay. I didn't jump in. I was really anxious. I could see things going wrong. Indeed, she had porous disease. We did do a biopsy. While we're waiting for the biopsy, do we irradiate these destructive bone lesions, Lisa, or do we just, the biopsy's going to come back in, it's probably going to be actually 24, 48 hours. We've got this window. Should we be addressing these bone metastases, or should we wait?
I think so first of all, it's difficult, and it's also interesting because I think most of us are actually more comfortable with the idea of offering radiotherapy without a tissue diagnosis of cancer than we are with starting systemic therapy. I would have done a biopsy. Have I ever given drugs on a presumed diagnosis of kidney cancer without a biopsy result? I have.
Me too.
So I don't think it's an absolute. I would rather have started drugs in this 38-year-old woman who could die extremely quickly and find out that my radiologic supposition is wrong than have not done that. But I would get the biopsy taken, is what I would do. And I would also discuss it with my colleagues, some of whom are sat in this room, and others of you are friends of mine, and I could telephone. So you think, am I doing something crazy here? But I would consider it in certain situations. The slightly easier question of would I consider offering radiotherapy for pending spinal cord compression? Yes, I would. I still don't know what I'm treating. It might not be the right thing to do, but doing nothing is also not always the right thing to do in my view.
Comes back as sarcomatoid renal cancer a couple of days later. We're good to go at this point. What treatment are we going to offer? Tom, Emma, do you want to start with me? Sarcomatoid renal cancer, widespread metastatic disease.
I would defer to my oncology colleagues. I don't think it's the place for a surgeon to be recommending a regime.
Nevertheless, okay, I'm fair with that. Tom W.
So I guess with sarcomatoid, I'd like to be offering Ipi-Nivo. You said she's got already deteriorating transaminitis pre-treatment, and she's got a number of concerning sites of disease, including the spine. So I think in this case, I would probably offer Cabo-Nivo.
Lise.
So Scott Shepherd, who's there, Kate Young, who's there, and Andrew Furness is there. We had an extremely similar patient about 1 month ago. The only difference is actually the diagnosis turned out to be an FH-deficient renal cell carcinoma. So 37 or 38, extremely aggressive presentation. We decided we wanted to give this guy Nivo-Ipi because he was young and we were looking for durability. And he was getting worse, and then we decided we would give him IOTKI. And then about 24 hours later, we decided we would give him Ipi-Nivo. And then he went into critical care, and we gave him IOTKI. So I would give this patient IOTKI. And I think it is really difficult. Which IOTKI? I think, I don't really like doing this, but Tom, I'll quote you back at you. Pick one, use it well. I would give either Len-Pem or Cabo-Nivo. I don't think it matters too much which.
And at least the mother came to me and said, look, we've, both of them actually, she had a complicated personal relationship. But it was mainly her mother and her that were driving this. What's the chances of responding to therapy? And she says that she's read that the Ipi-Nivo data is the one with the durable remission here.
I tell her she's right, it is. I mean, we all know that. So in terms of the things that we could debate, is there better potential durability with Nivo-Ipi in combination in high-grade renal carcinoma? There is, but there is also the higher probability or possibility of dying within the next 6 to 8 weeks. So I would tell her that she is right, and that I wish we had the time to wait for that, but that I'm really concerned that we don't. And so what is the likelihood of response? Well, the likelihood of early response is more than 50%, it's 60% to some degree, but we cannot guarantee on that.
We went with Ipi-Nivo.
And I don't think that's wrong. I mean, you know, having a debate is fun, isn't it? I don't think there's a right answer to this.
I think the wisdom at the moment is around Ipi-Nivo because of that fabulous sarcomatoid data. I think the CheckMate 214 data in this environment is super strong, and perhaps some of the other trials haven't looked specifically. I don't think there is any Len-Pem data, although I'm sure Len-Pem would work brilliantly well in this combination. The Axi, Pembro, you know, anyway, she got better, a little bit better. Performance status went from 3 to 1. Back pain better controlled. Mobilizing independently, not playing tennis, but mobilizing independently. When we do the first CT scan, is it important to rush in and do that scan?
I don't think so from what you've described. I think you're not in any doubt that the treatment is working.
We did it on cycle 4, day 1. Repeat CT scan, increasing shortness of breath, massive progression of disease. Progress very quickly. Significant deterioration, transaminitis gets worse. Died a month later. Maybe we gave her the wrong treatment. Maybe VEGF TKI would have been better. I don't know the answer. We weren't able to sequence VEGF TKI here. It was growing too quickly. And the answer to that question is when people say, oh, don't worry, we'll always get the treatment later on. That's not always the case. We know from the UK Real World series that actually only 40% of patients get second-line therapy. So the answer, I think, to this is that although I think Ipi-Nivo is a good treatment in sarcomatoid renal cancer, there are some patients who progress through still, and there is a debate about the right treatment. I'm intrigued that both of you went for VEGF TKI IO in view of the bone disease. With hindsight, I wish I'd done that too. Over to you.
Okay, case number 3, female, 45. She has a checkup for dysphonia, and a CT scan shows multifocal bilateral renal tumor, as you can see. She is flight attendant. The renal function is quite normal. So, Michael, what do you do?
That's going to be partial nephrectomy on both sides. I started on the more complicated one, and I don't have enough scans to tell which one that is. And if it goes well, do the other side in the same session. If the patient's not doing that well during that surgery, do it 3 days later on the other side. But I would do surgical removal. She's 45 years old. These are significant tumors. It's a renal score 12. They are centrally located. They're only going to get worse. They do look malignant to me without any doubt, so they need to come out in a young patient.
Michael, so would you, given that there isn't another surgeon here for you to debate against you now, I will ask you, would you biopsy? This is bilateral tumors. Would you biopsy first?
No, because the result of the biopsy is not going to inform my decision. It's not going to change what I'm going to do, no matter what it is. This needs to come out. If you look at the central tumor here, even if it's benign, it needs to come out. This is not angiomyolipoma. You can tell from these MRIs, and that would be the only situation where I would not go for surgery.
But could you tell me what you are doing on the right side?
Yeah.
You are doing a double partial nephrectomy?
Yeah. Why not?
With an open approach?
Yeah.
The big one is supposed to be not so difficult, the second one?
No, I don't
okay
think.
for you?
I don't think this is. These are both sides are partial tumors.
Okay.
And I think they need to come out. If it's the only thing is if it's oncocytoma, would you need to do that? But I think in a 45-year-old, you're going to face a surgical approach somewhere down the line. So I'd rather do it in small tumors, and oncocytoma are active systemically. So I would do it. Yeah.
With the risk of definitive renal failure.
I don't think
it's not so easy surgery.
I don't think she has a risk of definite renal failure here. There is enough remaining renal parenchyma to maintain her renal function.
We make a biopsy to the chromophobe RCC. The oncogenetic consultation confirm a Burkitt-Dubé syndrome. And again, I will give you what is your position on the tumor on the tumor number 1, open partial nephrectomy.
Yes.
And in the same time.
The same time.
You're doing.
I do.
Okay.
If it goes well, you can see it during surgery, and it should. Those tumors, if you open them up, they pop out.
Okay.
It is usually it looks much better during surgery than it does on scans.
Remember that she is a young woman, and she told you, yeah, okay, I would like to be very comfortable with my corporal situation, and please, I would like to have a minimal invasive surgery. Could you tell me if you can do that with robot?
So I'm a little bit concerned on the left side to do the robot, and I would be really concerned to do it in one.
The number 3?
In Sons.
Number 3?
3 and 4 with the robot.
3 and 4.
A little bit tricky. And actually, you can do a midline incision, it's like 10 centimeters. In a young woman, you can actually extend the tissue a lot, and it shrinks after that. It's like the same principle we see with cesarean sections, where it shrinks a lot after that. I'm not too concerned, and a midline incision is not going to destroy her body image too badly.
Okay. So we decided another option. We decided to make a surgery with robot for the 1 and 3, and to make thermoablation therapy by the radiologist for the tumor number 2 and number 4. If you've got the outcomes of the surgery and confirm a chromophobe renal cell carcinoma, and this is the situation in February 25. No evidence of disease, and the square inside the kidney, and a very good renal function. So Tom, number 4.
Thank you. A 68-year-old individual, various bits and pieces in the past, nothing super exciting. Bit of blood in the urine, not too much to worry about, never smoker. Renal function really good. no prior infections, autoimmune disease, fit and well. Flexible cystoscopy, doing an NAD, had a CT scan showing this large 12 centimetre necrotic mass. The CT scan showed no other problems, no other sites of disease. So essentially, he had a radiological 12 centimetre mass and no evidence of metastasis. Is a brain scan or biopsy required? Who wants to take that one on? Lise, do you want to go first? Maybe Michael. Michael, brain scan or biopsy?
I don't think so. And in most of the times on those CT scans, especially on those late phases that you have here, the amount of necrosis is vastly overestimated. And if you have a surgical specimen, you don't find that much in there. I don't think it will change my approach in this patient. If we don't have any further disease, then it's a surgical case and probably adjuvant therapy after that.
Yeah, this is a black and white kind of, isn't it? It's a big renal mass that needs to come out, and that's what happens here. PT3AG2, NX pathologically, radiologically N0, M0. What's your take on this, Tom? Do you give adjuvant therapy to the G2 T3s?
Yep, I do. So this patient would fall into criteria for adjuvant pembrolizumab, and they're in the high-risk group by Leibovitch score, so I would definitely see them in clinic and discuss adjuvant.
Lisa, what do you talk to your patients about in terms of the adverse events and the chances of life-changing toxicity?
So it's critical to discuss that because there is a clear risk of that. So I talk about common toxicities, less common serious toxicities, life-changing toxicities, and the small but definite risk of death from treatment. In terms of life-changing and irreversible toxicities, of course, we know about endocrine toxicities. In terms of someone's medical well-being and longevity from a medical health perspective, I am not most worried about diabetes, but we know patients are very worried about becoming insulin-requiring diabetics, and that must be discussed, both because it's a real risk of 1% to 2%, but also because people are worried about it when they go home and read the information leaflets that I no doubt you give to them. Often that's the thing they focus upon the most. So you need to discuss it also to remind people they probably know insulin-requiring diabetics in their lives already who are managing and living well. So I don't think the risk of that for me would not stop me from offering it, but it's critical to discuss it. And actually, in the end, it's not for me to decide how important that is for the patient, of course. So I do discuss that, and of course other endocrine toxicities, including hypoadrenalism, hypothyroidism, and taking thyroxine daily is possible. Taking whether it's hydrocortisone is a bit more of a faff, quite frankly, and managing long-term hypoadrenalism is harder, but is really important. You have to discuss the small but less common risks of serious cardiac, respiratory, neurological toxicities, and the risk of death, which is 1 in a couple of thousand probably, but actually we have had one also.
So we discuss adjuvant therapy with them as well and discuss the risks and benefits. About 65% of my patients choose to have it. This patient got into trouble after 3 cycles of pembrolizumab. They developed a series of symptoms consistent with adrenal insufficiency, which was shown on blood tests. We gave a 6-week steroid taper. We came off the drug. What do you do now? The patient comes back to clinic and said, well, I was told of all of these benefits, and now and I've also read that if I get adverse events, I might even be in the winning group. Do you keep going with the therapy, or is it time to stop? Which one of you want to take that on?
Yeah, so I would discuss both options. I think if you re-challenge with pembrolizumab, then this patient is definitely going to get further transaminitis. So I think that will be recurrent. I think the adrenal, in a way, is kind of done, so that's going to be lifelong and permanent anyway, so that wouldn't particularly influence things. But yeah, the platelet dysfunction and the transaminitis, I think, will recur. I think we don't know that you need...
Would you re-challenge it? Yes or no?
I would probably discuss the option 2 and try and dissuade.
So they just come back to you and say, yeah, whatever you think, I'm up for it.
I would advise against if it was just me.
Okay, I agree with you. Okay, so 14 months.
Can I ask you a question? The Leibowitz score in this patient is not going to tell us really what's going on here. This patient, according to the Azure score, has a 20% risk of early recurrence. Do you rescan prior to inducing adjuvant therapy, and if so, when?
Would one?
Yeah,
So,
we do.
In this individual, we didn't give more adjuvant, we stopped, and we did scan after we stopped.
We do a scan before introducing adjuvant therapy. Everyone who's going to have adjuvant pembrolizumab, we do a repeat CT scanning and an MR brain before we do it. If it's somebody with a higher risk profile than this, the Leibowitz 8+, we actually usually do those scans 10 weeks post-op to give the maximum time to see disease developing if that is what is destined to happen, so that if this person does have early metastatic disease, we'd actually be offering Nivo-IPI or some IO-TKI combination, i.e. so that we're not under-treating early metastatic disease. So we do rescan everybody, but we wait and wait and wait in the highest risk people.
So we're 14 months down the line now, and we've got an individual here with doing well, but sadly on some of this routine imaging, comes back with 4 lung nodules in both metastasis. Also developed anemia, IMDC, intermediate risk disease. Tom, what's your next step?
So I guess I could consider SABR radiotherapy to 4 lung nodules, but the timing of the relapse is pretty early, so I think the disease biology is not going to be good. Plus, you said they become anemic. The fact that they're more than 12 months means that I can offer them all options, so probably I would go with IO-TKI. I don't think I'd be keen on Ipi-Nivo in someone that's relapsing just beyond the year of adjuvant pembro.
And Lisa, of course, it comes back to this burning issue around re-challenging with immune therapy, which has been pretty spectacularly unsuccessful in advanced disease. You've got someone who's clearly at risk of immune-related toxicity. The immune therapy's failed pretty quickly. Would you re-challenge with immune therapy? Why not just single-agent sunitinib or cabozantinib?
So I don't have a randomized trial that tells me which is the better approach for this patient. No, there is talk about things such as receptor occupancy. So, and actually the receptor occupancy is probably quite low after 14 months. It's 10% or something. The toxicity that this patient has had does not preclude a further challenge of checkpoint inhibitor immunotherapy, in my view. There were 2 grade 2 toxicities with platelets and transaminitis. I have treated a patient in a different scenario who had developed grade 3 transaminitis and on re-challenge did not develop any transaminitis whatsoever. That was after a period of 2 years. So I do believe that this person is not precluded from re-challenge by the emergence of 2 grade 2 toxicities. And as you said, his hypoadrenalism is established now. That's not going to get better or worse by giving further checkpoint inhibitor immunotherapy. So at this moment, I would offer this patient IO-TKI. It's more than 12 months. I don't pretend I know that's definitely the correct approach, but that is what I would offer. With the caveats of on discussion with the patient if the patient wanted that, but by the Woodfire rules of what would I do, actually, if I were required to make the decision, that's what I would do.
And Tom, if you were going to give a VEGF TKI by itself, which one would it be? Would it be sunitinib or cabozantinib?
If I was going to give single-agent TKI, I wouldn't see any reason particularly to jump in with cabozantinib frontline if it's 4 lung nodules, so I would give sunitinib.
Whereas I would give cabozantinib.
So we did re-challenge with Axi-Pembro, and actually got away with it. I'm not sure it's the right thing to do. I don't think we should be re-challenging with immune checkpoint inhibition, in my opinion. This was a patient that I was co-sharing with someone else in the private sector in the UK. So I advised against it, actually, but the patient was informed about it, and they thought perhaps the immune therapy previously helped. I think we're using too much immune therapy in re-challenge, in my opinion. I think we should move away from it. I don't think we should be using it post-adjuvant therapy, and almost at all. And I'm concerned that we're driving in the wrong direction.
So I think we don't have time anyway. So thank you very much for the Woodfire session. And we are going to the last session with Lisa and
Ignacio.
Ignacio. Thank you very much.